Hi everyone. So we're just going to have a slightly longer look at common problem that we often find in the emergency department, but also something that's quite often missed, unfortunately. And these are tibial plateau fractures. So we're kind of just carrying on with our emergency radiology sessions. And yeah, let's hope we can learn something from this as well. So tibial plateau fractures, well, we'll get into the classification a bit later. But as we can see, the tibial plateau, of course, encompasses the proximal end of the tibia. It involves quite a few important structures around the knee, such as the anterior and posterior cruciate ligaments, the medial and lateral collateral ligaments, or what used to be known as tibia and fibular collateral ligaments. And, it involves the patella as well quite often. So these are quite important fractures and they're quite easy to miss sometimes. So what do we normally find? Of course, you'll find a patient with knee pain. You'll find a patient who, sorry, let me just get the pointer up. So you'll find a patient who has tenderness, so the lateral or medial tibial plateau. Pleural effusions are quite common, both anterior, posterior, lateral, medial, the entire knee just swells up. It's often associated with the vascular injuries and with compartment syndrome, often, but not always. So it's important to make sure that you check your pulses, to make sure that you look at the compartments, as the calf especially can get quite tense and it can be quite painful for the patient. And the best way to actually check for compartment syndrome is actually just to provide a bit of flexion onto the foot. And you often find that it becomes very tender along the calf, extremely painful. And that's how you know that there is a problem. They always require orthopedic referral. Doesn't matter on the grade. Make sure that an orthopod has a look at it. And of course, as we would expect for open fractures and displaced fractures and compartment syndrome, we would send them straight through to the orthopods. If there's a vascular injury, we'd also involve the vascular surgeons or surgeons. Let's just get on to the next part. So sometimes these can be very subtle. So if you had to look at this particular X-ray, just have a physical, a quick look at it, you might find it very hard to actually pick up a fracture. But what you might get is lipohematrosis. So lipohematrosis, which is what you call it, indicated here by this arrow that you can see here, is actually an extrusion of fat and of blood from the bone once it's fractured. Now, this is, oops, sorry about that. Let me just get this guy. So this is actually a very subtle sign, but if you do see it, it does indicate an intra-articular fracture. Now, once the patients have something like this, then all right, there is a fracture going on. Patient does need to be seen by an orthopod. It's often only picked up on CT or MRI that you can actually pick it up. So yes, it was just the enlarged version of that. Okay. Sorry, I've been doing a lot of presentations recently. I forgot what I've put in each one sometimes. Okay. So this was just the expanded version. And in the expanded version as well, if you try and have a look just at the X-ray, you might notice a bit of a disruption here, but it's very difficult to make out, especially in a busy emergency department where we often don't have the ability to sit with X-rays for a long period of time. You might notice a slight evidence of a fracture here, especially. So there's always these possibilities. And here we have the MRI of the fracture. So you can see it's a very subtle fracture, but it was definitely there. So let's have a look at another fracture. So this was a fracture of the medial end. Now, we're going to get to the classification, but this is a Schatzker 3, which is basically just a depression fracture. And it's one of those things that's also very difficult to make out. And if you look at this patient, there's actually no lipohematrosis that's come out. So, it's much more difficult to diagnose. And in fact, just looking at the X-ray and having a cursory glance at the medial end and the lateral end, there's not much to tell that there is an X-ray, there is a fracture over there. So it's one of those things where you have to go clinically, where you would, for instance, find that the patient has severe pain, has severe swelling, is unable to bear weight on the leg, things like that. It's one of those where if you are working in a more rural area, you may decide to put on some sort of support like a back slab and get an orthopedic opinion, because this patient's going to be in a lot of pain and really not being able to manage quite well, and these types of fractures are difficult to treat, and they're not necessarily that easy to sort out. Now you can see here, you can see the depression quite easily, as pointed out by this arrow. And if you compare this, for example, let's take the previous one, where if you look at the lateral end, well, this is now not the lateral end, unfortunately. Yeah, and here you can see I forgot to mention the lipohemarthrosis, of course, is superior. But here you can see that that medial end, and you can see how nice and straight it is. And then when you come here, that's when you can notice a bit of a depression. So it's just something to keep an eye out for, and something that can definitely happen. And here's an MRI of the fracture. So we can see it's just a depression of that fracture, so it's just depressed downwards. So this is normally with an axial force, so a force that's coming from the bottom moving up, or coming from the top moving down, and it forces the tibia into the femur or vice versa, and then causes it to fracture as a depression fracture. So let's try some, and let's just see. So if you want to challenge yourself, I suggest just stopping the video now, pausing it for a little while, and seeing if you can pick up the fractures. These are not difficult ones, but just have a look and see. And when you've done that, then you can come back, have a look at the x-rays. Okay. So if you've done that, or if you've just decided to carry on listening, here we can see this is quite a severe fracture of the tibial plateau. We can see the entire medial end, the lateral end, even the fibula have all been fractured. You can see there's a lot of swelling associated, soft tissue swelling. You would find a lot of lipohemarthrosis going on over here. We can even see what looks like air pockets. So this could be an open fracture as well. It's difficult to say from an x-ray, but it could well be an open fracture as well. And if we go to the second one, this is also one on the lateral end there, and you can see that there is a fracture. And here you can see a slight indentation, which may indicate that there's another occult fracture on the medial end as well. Now, of course, these are ones that you would refer to an orthopedic surgeon. They would have to have a look at the patient and decide what to do, although these are quite obvious. So this is the classification of tibial plateau fractures. So it's classified from 1 to 6. Generally, the lower the grade, the easier it is to sort out. The shorter the recovery time, the less complications associated with it. And the the higher the grade, of course, the more severe it is, and the more difficult it is to treat. So if we look at type 1s, we can see it's just a wedge-shaped cleave of the lateral tibial plateau, and it's normally caused by low energy trauma to younger patients with healthy bone. Type 2 is a split and a depression. And it's typically results from higher energy injuries. Okay, type 3, which we had seen earlier, is a pure depression fracture of the lateral plateau without any wedge. It's often caused by axial loading on the knee joint. Now, the one we saw was actually a medial, not a lateral, so it just confuses it there a little bit. Type 4 is a fracture of the medial plateau. Okay, so the one that we had seen earlier was actually a type 4, less common and associated with a high energy trauma. Type 5 is bicondylar fractures. They don't necessarily have to be in this pattern. They're just bicondylar fractures. It's a high energy mechanism and is often associated with soft tissue injuries. So type 6 is a fracture that extends through the metaphysis. It disrupts the knee joint alignment and stability. It's severe injury, often resulting from high energy trauma, and there's often significant soft tissue damage. So each type of fracture has different implications for treatment and prognosis. And as I had mentioned, the generally higher number types indicate more severe fractures that may require more complex surgical interventions and have a longer recovery period. Okay, so understanding the type of fracture helps orthopedic surgeons to plan the most appropriate treatment strategy, whether it's surgical fixation, conservative management, or other intervention. So this is a nice classification to know, even if you don't always get it right. So the easier way to remember, if anything happens just on the lateral side, it's likely 1, 2, or 3. If it involves the medial side, it's more likely 4. And if it involves the entire knee, it's likely 5 or 6. Okay, so that's just a way to remember it. And yeah, that's just a basic overview. And that's just a little joke to finish up. So if you guys have any questions, more than welcome to message me, chat on the group, and we can always answer them. But these can be very subtle, as we had seen before. So don't just discount a patient with knee pain. And knee pain is one of those things where even if there's no fracture involved, there could well be ligamentous injury. There could be soft tissue damage. There's a lot that's going on. So my advice is always and even for myself, if what you are seeing on the X-ray doesn't fit with the clinical picture, patient is in severe pain, patient is unable to bear weight, patient is unable to move without assistance, then that very often tells you that, listen, something else is going on, and it's best to get an orthopedic opinion. If you are in a hospital that doesn't have an orthopedic readily available, at least put the patient on some sort of supportive device, be it, even a back slab or a full POP if you need to, and you're not 100% sure, and get the patient to an orthopedic surgeon as soon as possible to be able to see what's going on. And as we had seen, X-rays can also be quite difficult to solve. It can be very difficult for X-rays to sometimes pick it up. You do need the higher modalities to be able to sort out what's going on. Okay, I hope you guys learned something from that, and hopefully we'll have another one soon. Thank you very much. Keep well. Bye.